Thank you very much, Bob. Thank you, Marianne. It is an unbelievable honor for me to be recognized by an organization with such strong roots in patient advocacy. I'm actually in the neuroendocrine world, relatively new into neuroendocrine, having probably only started in this subspecialty around 10 years ago. And then Janet, thank you for representing Louisiana. I think for all of our staff from the New Orleans program, I think we would all agree that Janet Merriman was very much a shining light in Kenner Hospital for patients that needed palliation. So I'm talking about surgery, and so as we're going into surgery, having listened to some of the morning groups, can we just define the word debilitating? Debilitating means that it would cause serious, irreparable impairment in strength and your ability to do things. It is never, ever our goal to have surgery cause significant impairment. The goal is to alter the course of a disease whereby you would have both quality and, most important, quantity of life. So I had the task of doing the surgery for the thoracic and the small intestinal midgut. We call those midgut. And I'd like you to better understand what variables weigh most heavily into surgical decisions, what data best supports surgery as a treatment option, so that when you are going and getting opinions from your doctors, you could better put into perspective what it is they're telling you, and even more importantly, you could come up with better questions that you would be able to ask to put your case in perspective. Explain how surgery is one of many treatment options that are not mutually exclusive, and this whole idea of morbidity, when people talk about morbidity, that is the likelihood of causing some debilitation, and that we always have to weigh the risks of the surgery. God forbid, we do not want it to be a trade-off of the current problem that we have for another problem. So morbidity is the complications associated with the disease. And why does that matter? Because it's super duper important to understand what the risk is associated with the surgery that someone would be talking about. So like the Whipple in the 89-year-old. So I'm not going to actually go into grade since Aman Chauhan went into the pathology thing, but the grade is super important. I think that we all talk about what's your Ki-67. You go onto those social media sites. You're like, oh, I got a Ki-67. I got a Ki-67. But it really does matter. The grade of the tumor is what gives us at least some expectation of the biologic behavior. And in surgery, it's super important because there is more or less data to support aggressive surgical intervention depending on the grade of the tumor. And then the differentiation status is really just how much those cancer cells look like crazy cancer cells versus relatively normal bronchopulmonary, meaning lung, or small intestinal neuroendocrine cells. And the lower grade, well-differentiated tumors have a more predictable biologic behavior. I think that Marianne brought up a really good point. Just because they are intermediate grade or higher grade does not mean they are unpredictable. It's just that when you're talking about surgery, you have to be a little bit more careful when you're talking about what the expectations are of the impact of that surgery on your life. So there are three main questions. And I think that I don't want to make a point saying, oh my gosh, the surgeon should always be the one that has to comment on the relevance of surgery. But coming from a surgical background, I think whenever anyone gets a diagnosis, they're like, can I get it out? Like they always have that in their mind. Can this be removed so I can put this behind me? And so even if the answer is that surgery is not the right direction at that point in time, I do believe that our role is to explain that to you from a surgeon's perspective. And once again, surgery is not mutually exclusive, meaning it's not always off the plate or on the plate. But can all measurable disease be removed, meaning the primary with or without the metastatic disease? What risks are associated? That's the whole morbidity question. And then what do you bring as a patient to the table that puts you at higher risk of having a problem with that surgery or recovering from that surgery? Once again, it's going to be a risk-benefit ratio, and God forbid we go Braveheart style into the cancer diagnosis, only to poke the bear of other medical conditions that would make it difficult for you to recover. So then I thought I would just go into some definitions, because then you can at least ask questions to whoever you're having the conversation with. So if we say that we're doing something with curative intent, okay, that means that we are going into a surgical procedure with the intention of curing you, eliminating this as a variable that would be a significant driver of your mortality. So that most of what we describe, whether or not it's colon cancer or gastric cancer, or pancreatic cancer, or whatever, is that ultimately the data that drives something is going to be, am I doing this with curative intent where I'm hoping to eliminate it as a variable in this person's life? Or am I doing it with different intentions? So a lot of times surgeons will throw around that whole cure word like really loosely. And so they're saying, well, what does cure mean? Cure means that when you're getting a diagnosis at some point in your life, you have every likelihood of living to die of something else. And for all of you 20 and 30 year people, is that there are a lot of us in neuroendocrine that would say with a low grade, midgut, even metastatic, we can get you to live to die of something else. Doesn't mean you don't live with you die with the disease, not of the disease. Now, palliative intent is kind of what Janet Merriman was commenting on, is that surgery is done oftentimes with palliative intent, but then I have to define what it is I'm trying to palliate. So I cannot palliate the fact that we have a diagnosis. I can palliate bleeding, I can palliate obstruction, I can palliate pain. I can go in with palliative intent to try to prevent something from happening if growth in a local area would be very difficult for that patient and cause them problems that would be life-limiting. But that the goal is different, so that if I'm going with palliative intent and I palliate bleeding and I palliate obstruction and I palliate pain, then we win. Okay, I have met my treatment goal of palliation. It does not mean that you don't live longer, but it means that by achieving that intent, you will likely live longer, because if one of it is bleeding, obstruction, perforation, or pain, oftentimes those things weigh heavily in quantity of life by no other means than the day-to-day burdens of the disease. And then the prolongation of life means that we are unable to eliminate all of the disease, but that there is enough data to suggest that my doing this, that, or the other treatment, including surgery, does have enough data to suggest that by doing this, it's associated with a survival benefit. That is extremely relevant in neuroendocrine. A lot of the surgeries we will do will be surgical cytoreductions. They will be done for prolongation of life, and with data showing that if we were to achieve that treatment goal, the patients live longer than had we taken a medical management alone. So surgery done with local, I just gave you some examples. So local disease with no evidence of distant metastatic involvement. So that can be a stage 3, node positive, completely resected, non-metastatic. So the favorable aspects of that disease is that 40% of people in that category will live to die of something else, will never have a neuroendocrine specific event over their remaining lifetime. Unfortunately, there are around 60% of people in that category that will either have or will develop metastatic disease over what can be an extraordinarily long life. That is one of the burdens of the disease, because there's this ongoing risk. That's why the surveillance guidelines go up to 10 years, and then depending on the age of the patient, it can be, in Marianne's case, we're up towards 30 years. So these are just examples. Midgut primaries, those are small intestinal primaries with lymph nodes. You take it all out. Pancreas primaries, non-metastatic, without lymph node involvement. Lung primaries, non-metastatic. Everything gets removed with the operation. Or we do use the word curative intent if you have very limited metastatic disease that can be completely removed, whereby we are leaving you without any evidence of disease at the end of the case. And there will be midgut primaries that have a single or 2 metastases in the liver, whereby removing all measurable disease, you do 2 things. 1, you have eliminated all the measurable disease, but 2, you have potentially kicked the can of even requiring systemic agents with somatostatin receptor inhibitors for that much longer, because although you will be at increased risk of developing additional sites of metastatic disease, there is not enough evidence to suggest that putting you on that drug at that point in time necessarily keeps that from happening. So, And that is done because depending on the age of the patient, when you're doing it, if you get rid of all measurable disease in a very slow-growing tumor, you may succumb to other medical problems before you would even experience the recurrence. Surgery done with palliative intent, I mentioned bleeding, perforation, obstruction, pain. So one of the things I didn't discuss, which is part of surgical cytoreduction, is when you remove enough tumor burden in the liver, which is usually the driver of significant carcinoid syndrome, is that by removing enough of that, you actually decrease the syndrome and therefore some of the complications of the syndrome. That would be palliating some of the, what we call intestinal manifestations of those midgut primaries, removing tumors where it's associated with pain, and then obviously the bleeding and obstruction. And the surgery for prolongation of life, I think, is where some of those multidisciplinary teams that were discussed earlier may have a little bit of differences of opinion. So that's why you have the checks and balances of a multidisciplinary group in terms of either institutional or national data that supports surgical cytoreduction in any given patient scenario. So surgical debulking or surgical cytoreduction is whereby you are removing a critical mass of the disease, whereby in meeting that treatment goal, there is enough evidence to say that those people live longer. And I can say that I have met, in taking over Gene Woltering's practice, hundreds upon hundreds of people that were felt to be inoperable because they were stage 4 at diagnosis, that I am still seeing, and they're still crying about his retirement, still seeing now 20, 25 years later, having had a surgical cytoreduction. There is no magic to 70%, although in our neuroendocrine world, if you aren't going to at least meet that critical mass of around 70%, then you have to sort of look at it in the context of other treatments that are available. But that when we're looking at it from a surgical perspective, our first question is, do I think that I can meet that 70% mark? And then obviously you have to understand the morbidity or the complications associated with that procedure for that given patient when you are not removing the extent of the disease, but you're removing at least some critical mass in a critical location, and that's a lot of the judgment calls that I think come with those of us that live in the world of the surgery side. So just to look at anatomy, I can just give you a little run of the course. I don't think I actually have any gory. I had to take out gory pictures in Rodrigo's talk, but I don't think I have too many gory pictures. So these are caricatures of the small bowel and colon anatomy, so that if your surgeon or your medical provider is talking to you about all the reasons why your case is difficult, it has to do with the anatomy of it's the vasculature, not so much the organ. So the small bowel sitting over here, do I have a light here? Yeah. No, maybe I do. Oh, yes. So this is the small bowel. It's just all pushed aside. And these are all the vascular arcades. And as they go from the sausage out here all the way down towards the main highway, which is your aorta here. Out here, super easy. Here, not as easy. Here's, and then I'm going to show you, we call this tiger country. This is the mesentery here. This is your colon here. This is the mesentery. And then your intestine sits above that. This is then the colon mesentery. This is the main highway where the aorta is. All of the critical structures to the bowel are within that mesentery. So it's all about mesenteric involvement. So then why do we talk about mesenteric involvement? Because most of the morbidity or the risk associated with the case are our ability to get it out of the mesentery. So this is just the same picture I showed you before. This is the sausage. This is a big rock, like sitting in the streams of arteries that are trying to get to this intestine. And what ends up happening is when you eat, your intestine says, hey, I need more energy. So it needs more blood flow. The blood flow gets trapped into this rock, and you have pain. So we call that postprandial, meaning after you eat, intestinal pain. I'm trying to not use medical terms. We call it postprandial abdominal pain. So, but that is because of this rock. So in order to get this out of there, I am heading closer and closer to tiger country. And you need to save enough bowel, or it's going to be a trade-off of our current problem to another problem, which is you need your bowel to nourish yourself. The anatomy of the mesentery, again, this is me, I think, telling you tiger country. So this is the sausage. If it's way out here, easy peasy. If it's out of here, these are the lymphatics in this picture. It's this right here is this little green dot right here. So then you have to take it with this artery right here, meaning that I'm going to take then this small bowel, but I have to take this colon. That is what the presenter from earlier was talking about, how we need to then take portion of the colon. We call that a right hemicolectomy. And so you lose more of your bowel if it involves vasculature that is taking on this poor little innocent bystander. The tumor is actually within the blood flow, but that unfortunately that blood flow is shared between this portion of the intestine and your colon. And then this is the center of the mesentery. That's when we start talking about significant operations, significant morbidity, and potentially the need for transplant. So that's the best lion I could come up with. So that's tiger country. So these are just some examples of what you see on a CT scan. That is very similar to that case that I just showed you. This would need a right hemicolectomy. And the reason that is significant is I agree with the presenter from this morning, is that for whatever reason, you can do that same operation for a patient with colon cancer in this portion of the colon. The same right hemicolectomy for a patient with colon cancer versus a patient with a midgut neuroendocrine tumor. And the midgut neuroendocrine tumor patients do not tolerate that as well with respect to bowel function. They tend to have a lot more loose bowels after a right hemicolectomy than the same exact operation done for a different diagnosis. So that, though, is not a debilitating procedure. It's a very well-tolerated procedure, and there are many ways that we can control some of that postoperative issue. So that mesenteric involvement there requires a right hemicolectomy because the vasculature is shared by the colon and the small intestine. So then if you were to look at this one, so this is one where it's a little bit deeper into the mesentery. Then I don't know, I put it like right around here. This is what the specimen comes out. You can see why this is the problem. The sausage is not the problem, but you lost a lot of sausage trying to get that puppy out of the mesentery. This is what we call a small bowel resection, meaning it did not share any blood flow to the colon, but that you lost whatever small bowel was involved with that mesenteric involvement. And then the base of the mesentery are the things that are most challenging. It happens to be one of the areas that I think that our program is probably most recognized for, is that how do you manage something in there? How do you manage a surgical cytoreduction with someone at the base of the mesentery if not actually encasing the most important real estate that is bringing blood supply to your entire small intestine and half of your colon? And no, not all these people need a transplant. So the complications of a midgut neuroendocrine tumor, ischemic bowel, is when you can't get enough blood flow, and therefore the bowel starts to lose its integrity. If you lose too much small bowel, you can get what's called short gut syndrome. That's different than just really refractory diarrhea. That's when you just do not have enough functional gut to meet your nutritional requirements. And then for people that have carcinoid syndrome, it can be debilitating. That's about rapid transit time. There are serotonin-induced things like diarrhea. That is where a lot of the pharmaceutical companies are trying to come up with other methods by which we can control that using like serotonin inhibitor type of methods. So now moving on to lung, which this is really Rob Ramirez's area, but you know what? I'm up to the task because the operations are not that hard to describe, but that bronchopulmonary net, if we were to just use the appropriate term, is that they come in these varieties: typical, atypical, multifocal, and then something that we think is a consequence of some of the abnormal metabolic issues within the lung and the neuroendocrine. We call that dip neck. That is not a surgically solvable problem. So the lung, very much like the liver, is a tree. This is your mouth, goes into your trachea, and then you've got a right and left, and then you've got the upper, middle, lower lobes, and you have the upper, middle, lower, upper, lower. So depending on the location, the operation that is required to take it out is different. But also, the type of carcinoid that you have is different. So if you have something where it's a biopsy-proven atypical carcinoid, those tend to be higher grade, more likely to go to lymph nodes. We are more likely to use a surgical approach to that along with a lymph node dissection. Typical bronchopulmonary nets are really slow growing, but more likely to give you symptoms that can overlap with a lot of other pulmonary hypersensitivities like asthma. Yes, and that we are, if limited disease, more likely to take a surgical approach in hopes of having it be one and done, but that the risk of multifocality is high, and we don't go in there like Braveheart taking out multiple tumors under those circumstances because they tend to be really slow growing. So the tumor location, once again, determines the operation that's required. If it's way out here, typical carcinoid tumors are not something that requires a huge dissection, so you can get it out with just a wedge resection, sparing a lot of the adjacent lung tissue. The closer it is to the hilum, the more likely you're going to need to take out an entire lobe. We call that a lobectomy. And although not commonly employed, we have probably at least 24 patients that we follow in our clinic that are at least 10 or 20 years out of a pneumonectomy, meaning you have to take an entire lung out just because of how it's hugging the most central anatomy of the airway. Multifocal is when you will often have small volume disease in both lobes. A lot of times we will either at a minimum biopsy that, at a maximum do a wedge resection in order to document the grade of the tumor, but that there is not a lot of evidence that doing multifocal resections actually prolongs life in bronchopulmonary net. And that the treatment options are not mutually exclusive. So somatostatin receptor inhibitors, which is the standard of care systemic treatment for somatostatin receptor positive tumors in people with measurable disease. You have chemotherapy that you learned about for higher grade tumors, liver-directed therapies you learned this morning. We have PRRT, and then surgery is just one of those options, of which your multidisciplinary team is what tells you what you're going to do. So this is just my car and parking space analogy that I use to explain kind of the concepts that we use in neuroendocrine. So really, if you were to talk about the drug that we use, it's like injecting you with a bunch of little cars to drive over your whole body. They're looking for a parking space. Really, it's a receptor called the somatostatin receptor. And like a police officer putting a boot on the car, it is trying to cripple that cell, keep it from spewing out stuff that gives people symptoms, but also mess with the mechanisms by which it divides. So a lot of what we're trying to achieve is a balance between enough cars, blocking enough parking spaces, and or enough treatment that keeps a disease in check over a very long period of time. So then if you were to look at the types of treatments that we're using, surgery or non-surgical, the drug is like the boot on the car. The surgery is like taking a shovel to multiple areas in your lawn, but you can get rid of a whole lot of parking spaces with a surgical resection. And so if you were to be able to downstage someone and remove a critical mass, 70% or more, then it's associated with a survival benefit, probably because you then have less disease burden that is necessary for the other treatments to keep in check. And then obviously liver-directed therapies where we shoot the little bullets, I say that's like taking your air rifle to the arcade and you got the targets that come up and interventional radiologists can shoot individual targets. It's excellent. 80% chance of having a significant objective response and can downstage the number of tumors. And then the survival is the strongest in low-grade variants. The 70% is our goal. It's got less robust evidence in metastatic PNET. That does not mean that there is no evidence. It's just that if someone seems like they're being a little Debbie Downer, it's likely because they just don't understand some of the differences in how we interpret the data. And there's definitely weaker evidence in metastatic lung. It doesn't mean that we've never done it. It's just that we need to better understand the risk-benefit of any individual case. And then in high-grade tumors, if we're not doing it for palliative intent, there's just not enough evidence to suggest that we should be doing major surgery in high-grade tumors. So my advice is that the treatment plans for NET need a multidisciplinary input. You already did that. That there's a number of people at the table that are part of the checks and balances of our system. I believe that recommendation about surgical intervention should come from a surgeon. It can be used alone or in combination. They must be used judiciously because, God willing, patients with neuroendocrine tumors live a very long time. And keep copies of your pathology, op reports, images, and clinic notes in case you need a second opinion. But also, I think that if you live a long time or you move, it's really important you have it all in one place. Okay, and that's how you get in touch with me. And then Bob is telling me that I need to talk faster. What time is it, Bob? Oh my gosh, I can easily finish by 3:30. Okay, so then Mike, are you putting on the transplant? Okay. So while he's getting that, or not, tell me when you're ready. So I actually entered neuroendocrine in the world of transplant. So I was at Indiana University, and my division chief came up and said, hey, Mary, do you think it would be crazy if we thought about using uni-organ, meaning single organ or multivisceral transplant for the treatment of neuroendocrine? I said, no, it's not unreasonable in highly selected patient populations, but I will warn you that people are going to care. So before we take like 18,000 bullets for doing something like transplant on a patient population that lives a long time, we need to just be really careful that we are explaining ourselves. So Rodrigo was with me when we built the program at Indiana, and what it was that patients would be sent for an opinion, not because it was the disease, but that it was over years, if not decades, of treatment for which they had suffered organ insufficiency or complications of surgery or abdominal catastrophes. So people like Gene Woltering were calling saying, would you be willing to do this because you were doing it for other patients with different indications, and so therefore you had the skill set to do it. So as Bob said, I will never be able to channel Rodrigo Viana. He is an incredibly charismatic, not to say he is also very good looking, but he also has an incredible like Southern American accent. So there is no way I will be able to channel Rodrigo Viana, but he is a very, very close professional, friend of mine, and an excellent surgeon. So transplantation in the setting of neuroendocrine, it's not like you're saying, oh, we're just going to go big and go home at the get-go. That is not it at all. So people that live outside of transplant are like, are you kidding me? Like, none of us wake up and go, God, I wonder if I'm going to need a transplant in this lifetime. It was about looking at the clinical scenarios whereby it would make sense. And I think that if you are on those social media or the support group sites, is that there are people that suffer with the complications of this disorder over a long period of time, for which there is clear evidence that transplantation would likely be able to solve that problem. So it is not meant to replace any of the standard methods by which we currently operate, and it is usually associated with single or multi-end organ dysfunction. I can go over some of those examples, and the disease does have to be limited into the abdomen, even though Dr. Woltering begged us to do some of the patients with bone metastases. We have to understand that transplantation is one of the most highly regulated fields in medicine in the United States of America, so you can't go willy-nilly choosing transplant. So if you were to look at like an isolated intestinal transplant, and then I have some of the pictures that go back from my last talk about what that means with respect to like that major highway right in the center coming off your aorta. So the types of things that you would use an intestinal transplant for is people that have had the sequela of either multiple surgeries, complications from surgery, or for whatever reason, they have what we call intestinal failure, meaning that they are either TPN dependent, wholly or partially, or they have other intestinal problems. Intracutaneous fistula is when you have breaks in your intestine and it's coming through some other part of your body through a drain or through an ostomy. Or you have something at the base of your mesentery where it's tiger country, and there is no way anything short of a transplant is going to be able to remove that without risking the entirety of your small bowel. So there are very clear-cut indications for intestinal transplant. It's actually probably the more common transplant that we use, because you can take someone from all of those disease processes, and in using a transplant, you would correct all of it. But that it is not used for metastatic disease. So it's a very highly selected group of patients that would be relevant. So a liver pancreas transplant is also called a upper cluster. We did not start our program doing upper cluster transplants. We were a little bit concerned that we weren't going to be able to clear all the nodal disease, but that it's predominantly for metastatic pancreatic neuroendocrine tumors that were low grade with liver-only involvement. And usually the liver-only involvement was something where the risks of some of the treatments that we would use, including liver-directed therapies, were likely to cause liver failure over time. And so in doing the liver and the pancreas, you would be removing the extent of disease. And then some of the complications associated with pancreatic neuroendocrine tumor surgeries, whether or not that be portal vein thrombosis. So we call that some of the abdominal catastrophes that can happen after an operation done with curative intent. And so we're using the liver pancreas transplant actually as a salvage operation to solve those problems. The multivisceral transplant is the one that we probably put on the map because it addresses most, if not all, of the issues that neuroendocrine patients would have. It is predominantly used in metastatic midgut. That's what the metastatic ileals or the intestinal nets. It is people that have a lot of liver and or nodal involvement, whereby you are able to then clear all of that disease. The base of the mesentery with total mesenteric thrombosis, it caused all of these massive venous collaterals that can be prone to bleeding risk and things like that. And then multi-organ site insufficiency, meaning that you have either liver and or intestinal, or because of how those two things communicate with other, you have both organ insufficiency. I don't use the word failure because it doesn't have to be TPN necessarily dependent in order to get a multivisceral transplant. But we select these patients really carefully. They tend to have to be younger so they can withstand a major operation. But a multivisceral transplant can render someone who would otherwise never be able to get rid of all measurable disease without measurable disease. So this is just the example that actually Rodrigo had. So this is the tiger country. This is where this is just you lying on a table like a loaf of bread being cut up. This is the aorta. This is encasing right up to the aorta. There's no way you would be able to get that off without sacrificing the entirety of the small bowel, but that because it is either metastatic or a lot of nodal involvement, you couldn't get away with taking the other organs with you. So this was a 48-year-old with an insulinoma. Those can be extraordinarily difficult to treat because they are so glucose dependent. And then in many cases, especially in Indiana, because we had a surgeon, that was me on the thing, and then also the transplanters, we would make every attempt to try to see whether or not we could, we could snake it off of there and save the intestine and then only use the MVOT as a backup, but that this guy obviously ended up having to need the MVOT, and with last follow-up, he was 8 years out. So this is a liver dominant. I actually have a gory picture, but I'll tell you to turn away if you don't want to see the gory picture. So this was a liver dominant disease with disease limited to the abdomen, but multi-organ, liver failure from greater than 50% involvement. Glucagonomas are also incredibly difficult to treat. They give you this really, really significant skin manifestation of this disorder with these weird rashes. This patient was transplanted in Indiana in 2008. Now, you're going to have recurrence, just like you necessarily would with almost any cancer that in terms of if you are taking it out, you're always going to have some risk of recurrence, even if it's low. So this person did recur in 2011, is still alive today, and he's stable on this drug. We switched him to sort of an anti-proliferative drug, everolimus, which is also an immunosuppressant. but there's a lot of misinformation about the role of immunosuppressants in the biologic behavior of solid tumors. I spent 3 years in the lab at Cornell asking this very, very question. There is not any significant evidence in neuroendocrine that the immunosuppressant protocols that we currently use would change the biologic behavior. So it's not as if the recurrences come back and they are some ugly cousin of the original diagnosis. So this is the before and after. So if everyone wants to turn away from the gory. So this is that's the patient. This is, you know, how gross it looks. This is what it looks like after they have removed all of the intestinal organs, and that's what it looks like afterwards. That was Rodrigo's picture. So the imaging that we use to make sure that we are selecting patients appropriately is an SSR PET. You can imagine that we are making these decisions prior to gallium-68 being FDA approved. So we did gallium-68 on what the FDA calls an investigational new device application specifically for this purpose, so that helped us improve how we would be able to understand the actual extent of disease for these patients. And then we use what's called a CTA or a CT angiogram to better understand the anatomy of the vasculature, because obviously you have to end up plugging these things in to the native vasculature that's left behind. And then these slides are really in case Marianne has these slides available to you. You would know that I'm not just touting this because we did it, but that there actually is peer review, meaning a jury of your peers have said that we aren't, you know, crazy for considering this. There are a number of other centers, both internationally and within the U.S., that have done this successfully with very reasonable outcome. And this was the conclusion of that paper that pretty much said if you select people appropriately, we should not deny people the same type of life-altering or life-saving transplant that we would patients that were being considered for transplant for other diseases. So this was our experience from Indiana that Rodrigo promises me is updated to today. We did 14 patients between those years. Those were the diagnoses. 9 of the patients are still alive, and there were 2 deaths related to sepsis. So this is not for the meek, but that we have to understand that the patients that were being chosen were likely going to succumb to the consequences of the treatment of the disease as opposed to the actual cancer progression. So it wasn't as if you were kind of doing it a trade-off of one, is that had we not given a shot with some of the inherent risks of it, they were likely to succumb to their disease a lot sooner than you would predict based on their neuroendocrine biology alone. So then we had a little program self-evaluation so that we looked at all of those patients that we had done and said, hey, you know what, did we lead with our heart or did we lead with our head? And I think that we sat around, Rodrigo, me, and the chief of our division, and we sat around and said, hey, you know what, I think perhaps in 2 patients we probably wanted to do something because the person was in a dire situation where we didn't have as much evidence in our own hands that it was ultimately going to change the course of the disease. So we changed our protocols accordingly to make sure that we were leading more with our head and less with our heart when you have a lot of people flying from all over the country in hopes of you doing something heroic. There are guidelines. So there are European guidelines as well as U.S. guidelines. The European guidelines tend to be considerably more conservative, but I think that's just indicative of the way they practice medicine in Europe. So it just has really to do with the grade. We go up to a 20%, and then most of the other things are the same. These are our UNOs. That's the organization that controls the organ allocation in the U.S., and these are the parameters that we use. And it's not like, you know, we're ageist or anything. It's the fact that it's the recovery from the operation, that just the physiologic stressors on someone that is older compared to people that are younger. So in Europe, they cut it off at 55. I have no doubt that probably Rodrigo has likely pushed this envelope before, but these are the guidelines that UNOS keeps us to. And then the survival liver transplant, this is 75% at 5 years, 65 to 70% at 10 years. That's going to be, if you were to look at the expectations of survival in this patient group, it is well below that. And if you were to look at that, that compared to, so liver transplant is setting a benchmark on this. And so to get 60 or 70% 5-year survivals and 50% at 10 years in something like a multivisceral transplant would have been almost unheard of probably around 15 years ago. So I think we're making a lot of progress. And the post-transplant management is we now use an everolimus-based thing. This group probably doesn't need to really understand that drug, but that has a lot of anti-cancer properties along with it, and I think that has decreased the amount of recurrences that we've seen post-transplant. We have serial imaging with gallium PET imaging. It's really now copper, and that the therapies for recurrence can include any of the therapies that are available for non-transplant patients. And these are the centers. Now, this may be a dated picture because this is also from Rodrigo. So the intestine transplant centers are the ones that are going to be in the multivisceral organ transplant referral chain, even though not all of these areas probably do multivisceral transplants. For the most part, the vast majority of transplants that are from our program are going to go to one of these two centers, but that doesn't mean that I think Mount Sinai is an awesome transplant program. Probably the Northeast probably goes into Mount Sinai. I think that's it. Oh, and the conclusions. That transplant does offer definitive resection for non-resectable, meaning that we are not using it as an alternative to other surgeries. Patients who are considered for transplant are likely not candidates for other treatments. The new imaging has helped us select patients more appropriately. There are guidelines, so we aren't just going out to the wild, wild west, and the timing of transplant is critical. I think for the most part, that 6 months is a little arbitrary. We will usually target patients that have single organ or multi-organ dysfunction, are potentially somewhat TPN dependent, and therefore there are a lot of issues with that in terms of potential liver failure, and that they have likely had the disease for a long period of time and are struggling with some of the consequences of the treatment. And that is it. Is it before 3:30?